So good morning everyone. I'm Amanda Hogan. I am the NHS Sickle Cell and Thalassemia Programme Manager, leading for the antenatal and newborn screening programmes. And today I'm here to discuss the process of giving newborn screening results to parents and looking at our new proposed protocol for giving results to parents. I'm going to talk to you, give you a brief introduction. It's only going to be brief because I've been given 10 minutes, and I think the slides will, the information in my slides will be built on throughout the day. So newborn screening, it's an important process. It identifies newborn babies where there may be health issues before they show signs of symptoms. The focus is always on early screening, early treatment and early intervention. And what we know is that there's huge advantages for performing newborn screening in England. And it's well evidenced and well described in the literature. Any screening programme is based on international recognised criteria and is always supported by rigorous evidence. And for the newborn screening programme for sickle cell disease, there is lots of evidence out there that there's advantages in screening for sickle cell disease. For thalassemia or carrier results in healthy infants, the same evidence isn't there. However, we do pick it up as part of the sickle cell screening programme for newborns, and where we pick it up, we do identify it. We will always refer as needed. We do actually refer into treatment and follow the same quality assurance processes that we have for sickle cell disease. And that's why we've included it as part of this presentation. Generally, the screening process for newborns starts on day 5. It picks up 9 conditions, rare conditions, but it picks up 9 conditions. And it's a relatively simple process. It's taken a small amount of blood from a heel prick test. And as a health professional, as a midwife, it is quite a simple, straightforward process. But it's also part of a pathway, a much bigger, complex pathway. It might involve further testing, it might involve genetic counselling, referral to treatment. And there are many health professionals involved in the pathway. The other thing about the screening pathway for sickle cell disease compared to the other newborn screening programmes is that it can start antenatally. We need, it's an inherited condition, we need the biological parents' results in order to analyse the newborn results. We need the prenatal diagnosis results where they are available. That's the amniocentesis or the CVS results, in order to link that to the newborn results. So you could say that in terms of a pathway, it starts in the antenatal period. So the presentation does cover 4 areas. I'm going to give you an overview of the programme. I'm going to just introduce the project, talk about the importance of outreach and engagement and the next steps. So, antenatal and sickle cell and thalassemia screening is in place to identify pregnancies, or pregnant women and biological fathers who are at risk of having a baby with a major haemoglobin condition. And that's important because we want to give information to pregnant women, to families early, so that they can make a personal, informed choice during their pregnancy. For newborn screening, we want to achieve the lowest possible childhood death rate and to minimise childhood morbidity. Again, to make sure that we've got early identification of babies with the condition and make sure there's prompt treatment and follow-up. And we want to improve the outcomes and the quality of life for people with the condition. Just to give you an idea of the scale and what that looks like, is that each year we offer screening to around 650,000 pregnant women. We pick up about 14,000 high-risk cases, and with all of those cases we offer counselling, genetic counselling, Where there are high risk or severe conditions suspected, we will offer prenatal diagnosis, amniocentesis or CVS. And in England each year, 400 prenatal diagnoses are performed. For newborn screening, we test 600,000 babies each year in England. Across the UK, it is 700,000 babies, which equates to about 220 positive cases and about 7,500 carriers that we pick up. So it's an enormous screening programme. To give you an overview of some governance around the programme, we have 9 screening standards, 7 antenatal and 2 newborn standards. I'm just going to focus on the newborn standards today. We have a standard 8, which is results must be given to parents by 28 days. The 28 days is in place because it can be quite a difficult, complex test in terms of analysis, and we might need to do further testing, so it can take up to 28 days. And standard 9, which is referral into treatment by 90 days. It's important that babies are into treatment by 90 days because we need to start penicillin to make sure there's no infection within the first year of life. And we are supported by other standards, so newborn blood spot screening standards are also relevant to our programme. We have a number of educational and information resources available for health professionals. So we have some information for midwives, GPs, health visitors. So health professionals who will have contact with families with sickle cell or thalassemia, and they will need some basic knowledge around autosomal conditions such as sickle cell or thalassemia. But they're not going to be giving the genetic counselling. They may need to have the fundamentals in terms of giving women or families some information on things like familial inheritance or inheritance patterns. So they need some basic knowledge and information, and we have a number of resources that meet that need. And then we also have specialists involved in the pathway, and we have more specialised update days or laboratory workshops for scientists that are available that we support and update. And I know Emma's going to talk more about the e-learning package that we have in the programme. I'm just going to point out our Counselling Knowledge and Skills Guide. There's 8 modules in that guide. They're all aimed at specialist genetic counsellors. However, there are some areas in there that would actually meet the needs of midwives, health visitors and GPs. And if I'm contacted about training or updates, I tend to signpost people, health professionals to this particular guide, and there's lots of resources in there to help understand the screening pathway, understand genetic counselling, and there's lots of links and information in there as well. In terms of the project, so the resources that I just have picked out, they're information and training that a health professional would need to book time in their diaries, you know, whether it's mandatory training or CPD. They'd have to think about updating themselves with that, with those resources and that training. The project is about just in time. This is about having a resource available where you have a family that you now need to discuss a positive result or a carrier result before referring on to a specialist counsellor. So we already have a document. It's called Protocol for Reporting Newborn Results to Parents. And I thought it would be a very simple, quick task to update this document. And I was wrong. I couldn't have been more wrong. The level of detail in this document and the amount of information meant that you couldn't just update the protocol. I should have known better. When you're talking about sickle cell and thalassemia and the screening pathway, it's one of the most complicated pathways and is a very complicated condition. So a year later, we're not quite finished. We're nearly there. We'd have liked to have been here launching this document today, but actually it wouldn't have been the right thing to do. We need to get this right. It's quite critical that we get this document right. In terms of the principles of the document, it needs to set out very clearly what you would do when you have a family that you need to contact. So some easy steps, some principles that would guide you, that you could just pick up the document as you needed. In terms of the update, we wanted to make sure that we understood current practice. We wanted to understand what methods were out there in terms of conveying the results, understand if there was any variations in the process, regional variations. We wanted to make sure that we knew what the support needs were for women, for families, parents, and that was also in terms of what did they need if they wanted to discuss the result with their families. Maybe they wanted to do some cascade testing and have further communication with their families. We also wanted to ask, do we think parents regard carrier results as valuable? Do they want that information? Would they seek to share this information with families and inform their children in the future? We didn't know the answer to that. We've got lots of soft intelligence. We've got lots of feedback when we were out there implementing our newborn outcome system. But there isn't really much in the literature. When we did our literature search, there wasn't really much discussion on how to give results to parents. There's lots to say, yes, there's evidence we should be doing screening for sickle cell disease, but how to do it. We've got the work by Jane Chudley, she's here today, who works at KCL, who's a researcher and senior lecturer who has published some work on results to parents. But more work needs to be built in. We need more information on that. So what we did is we asked the societies to help us to get some user feedback. We wanted to know what are the reactions of parents to getting a positive result or a carrier result. How do they feel? Are they shocked by the result? If they had prior knowledge of their carrier status, does that help in terms of, is there less distress or less anxiety? Preparing a family for a result prior to actually getting the result, does that help? Are they more equipped? And the methods of delivery of results. Can the way we give a result cause anxiety? Are we causing anxiety and distress to parents? Can parents feel that they're left in a vacuum, awaiting for results? Or can parents fear that their child had a serious condition if they are waiting for the result and they haven't spoken to a health professional and it's 2 weeks down the line? Are they worried that there's something more sinister going on? The best way, we thought, of getting user feedback, and a resource that we use all the time, we have quite a close relationship with the societies who do pieces of work for us each year. We wanted to engage them in some outreach and engagement work to help us get that user feedback. We wanted user feedback to influence what we write in that document. We wanted to know where there might be cases where there's delay in the pathway, how parents felt about the perceived delay or the actual delay in the pathway. We wanted to make sure that we were engaging with families so that they had trust in the screening pathway and they were engaging with the service in the first year of life. And we wanted to engage user feedback because there are disparities that exist in healthcare for some ethnic groups. and that can lead to poor outcomes. And we know there's been reports highlighting inequalities, substandard care, stigmatisation for patients with sickle cell disease. In terms of next steps, we need to update our protocol, update our information and resources to reflect the work that we've gained using outreach, make sure that user feedback is built into whatever we do, and we will launch the protocol within the next couple of months.